You should go on the more. Hide
video cam.
You think?
Hide floating meeting controls.
Yeah. Okay. Right.
Okay. Thanks, Matthew.
Yeah.
Okay, nice to meet you all. I'm going to give you a quick whistle-top tour of all the stuff that I do. So it's kind of, I'm not going to go into any depth about any results or anything like that. It's going to be presenting all the different bits of work and then some of the challenges that might be involved, and that might give you an opportunity to think where you might be able to help with some of those challenges as well. So I'll take you through what got me into this kind of digital health sphere first of all, and then we'll cover how it looks like it was two disparate things that the pandemic really kind of highlighted the links between, because in the pandemic, of course, the healthcare workforce were really burnt out, training was suffering, it highlighted some of the gaps there, and also mental health was a real casualty of the pandemic as well. So those two things that I've been working on separately kind of have really came together in a sense in that way, but the other thing that brings them together is simulator training. So first of all, my role in Heriot-Watt, as well as being a psychology lecturer, is I'm heading the digital mental health and neurodevelopmental neurodegenerative disorders theme of our relatively new Global Research Institute for Health and Care Technologies. So this is an opportunity where we will be working cross-institutionally and with companies, etc. as well, to try to bring expertise in. So there's a lot going on in the GRI if you've got any interest in that more generally, because there's a few different themes, 5 main themes and different cross-cutting themes as well. Just do get in touch with me about that. But this is me and this little theme here, which is turning out to be quite more than a little theme, really. There's a lot of interest in this area. So I'll tell you a bit about my background, then about some of the labs that I'm working on as we go through each of the different stages. And I'll start off talking about the medical training side, then before going on to the mental health side. So I did actually my undergraduate here at the University of Glasgow in psychology, and which was lovely, and that's where my interest first started in mental health and clinical. I was interested at that time being a clinical psychologist basically, and then became interested in research. And during that time, I set up a mental health charity for children who have parents who've got mental health problems, and for the parents as well. So that kind of stemmed through what I was doing there, and then I went to Strathclyde to do, first of all, didn't really know what to do, so I did a master's at an MRes, and then stayed there to do my PhD, which was in eye tracking. It's kind of ironic because Glasgow University is full of eye tracking, and I was terrified of it when I was there, so I kind of avoided anything that was a bit too techy, and then ended up doing it at Strathclyde. So yeah. So I was really interested in attentional biases and social perception, and when you're giving a speech like this, how you pay attention to anybody who's fallen asleep, bit bored looking, kind of looking at you like they think you're talking nonsense or anything like that. And these are all the things that go on in your head when you're maybe giving and so I was interested in looking at how we can use that knowledge of attention and interpretation to try and help people to overcome that in training paradigms. And I applied for some funding at that time. It was to what used to be Technology Gateway. This was before Innovate came in, and got some funding to work with Glasgow Art School and some avatars, and did some studies looking at that to train attention and interpretation really through gamification. So that was quite cool, and I was really enjoying that, and I thought I could see some potential there, and I started to look at commercial applications as well as clinical applications, just on general, for companies and that kind of thing, actually, just helping people to become more comfortable with presenting. But I learned a lot from doing that particular study as well, which was primarily the level of personalization that is really required for giving people digital mental health training. A one size will not fit all, and there are many different types of profiles that need to be catered for there. So while I was doing the social anxiety work, then I thought, I started to get more interested in the eye tracking side as well, and thought I wonder what else it can be used for. So I started to look around, and I was looking at commercial applications as well. And I realized that there was a real gap in the market around critical safety. Everything was in advertising, basically, or web pages or that kind of thing. There was nothing happening in critical safety. So I became interested in that and started writing some grants with my PhD supervisor at the time and various other people, and to fund some RA posts throughout my PhD, looking at different ways of applying eye tracking. And one of them ended up being a research fellow towards the end of my PhD on an EU project looking at shipping. So we were eye tracking officers of the watch and sea captains as they, navigated a ship, a bridge simulator, basically. So that was in Germany, and that was the simulator there. And then we also got involved then in designing VR scenarios for engine rooms for safety in shipping as well. So that was in Spain. So did lots of that work and learned again a lot from that. When I came back, I thought, okay, so then I was graduating from my PhD and I thought, what am I going to do with this? Happened to run into the medical physicist at Dundee University at a conference, and I was talking to him about this idea of critical safety. He introduced me to a consultant anaesthetist at University of Dundee at Ninewells Hospital. And the Optimize, which is a company I then created, was born from that initial meeting, really, because he had a problem where he was trying to train anaesthetists and couldn't understand why they couldn't get what he was saying, basically. So we thought eye tracking might be useful there. I then realized that actually the big problem with that, with mobile eye tracking at that time, was it was horrifically slow frame by frame video analysis, which was, it was something. And I thought, this is never really going to work in training. This is purely for research. You can't really apply it if you can't give people the right kind of feedback that they really need. So I then applied for a Scottish Enterprise grant to Smart Grant to develop automated software, essentially, to be able to give them instant feedback as their training, which is what we did. And actually, while I'd been at Glasgow, I'd worked as an RA in higher education, and looking at things like feedback for students and that kind of thing. And I kind of took that job at the time. It was great. I was just finishing my undergrad before starting my master's, and thought I wasn't really that interested in that area, but it's actually served me really well, because coming back to this medical education now, I can draw on a lot of those principles. And so because I was getting involved in this, basically I finished my PhD 2000, just into 2013, beginning of 14. And just at that time got funded for the company, but just before I got funded, I wasn't sure if I was going to get funded or what was going to happen, so I applied for a job at Heriot-Watt. So I got that as well in something like the same week or fortnight. So then I was kind of like, wow, got both of them, great. That was quite tricky, negotiating all of that and trying to manage all of that, until I then thought, how can I make all of this work together and make the company stuff part of the academic work that I'm doing, really. So I set up this medical education lab where it wasn't just about eye tracking or my company, it was about giving people in the university and across different universities and other companies an opportunity to get involved in this picture of changing medical training into simulation training, because medical training is actually it might be quite surprising for some people to learn how much training is done on the patient. And that's kind of, it was a bit of a surprise to me when I realized how subjectively it can be scored as well. So there's a real need for simulation training, particularly now after the pandemic, even before that, with staff shortages. Then you're not getting the same trainer time. So they really need repeated practice, lots of repeated practice. And one way to do that is to have them in simulators in situations that don't necessarily depend on a trainer being there at all times, so they can get extra amounts of practice. So the problem with ultrasound guided regional anesthesia, this is where you're getting a regional nerve block around, so you have to inject in with millimeter precision around a nerve, looking at an ultrasound screen. Now, if anybody's ever looked at an ultrasound screen, the picture's quite fuzzy. It's quite difficult to see. And as you can see here, you know, where is a nerve? There's just lots of stuff going on there. And it's really very difficult to visualize that anatomy for a trainee to understand what is happening and follow it. And we know that regional anesthesia is something that there's evidence that it benefits patients in terms of pain recovery and hospital stays and reoccurrences and relapses, etc. So we know that there's value in providing this kind of training, but it's before now there hasn't really been a great solution for that. And also there's a problem worldwide with access to medical care and medical training. And so that's, you know, again, we need to look at where the gaps are and see what we can do. So our vision really is to try to help students feel more prepared. My daughter is now a junior doctor and facing all of these challenges, and I know what training is like from both sides of that. So we want to try and help students, but also help clinicians and patients primarily all over the world to be able to achieve the best medical care they can. We can only do that through collaboration. So this is where there may be opportunities for people to see where they might be able to input in that bigger kind of picture. So we've done some work. This was us working with B. Braun and Phillips on a study to evaluate their needle tracking technology. So that was a great project that we worked on. And we've seen firsthand, as I said, most of the training is on patients. So, you know, why is it important? Now, this is something that I'll come back to as one of the challenges later, but one of the challenges is funding around this area, because I feel that funders don't always appreciate this part here. The training is sometimes thought to be considered to be continued professional development, rather than actually, how does it actually benefit the patient? How is that? And I've been there and seen trainees giving injections on patients. And, you know, I think you can see an expert doing it, you can see a trainee doing it. And when you're actually there, it becomes very obvious why that's important to have some training beforehand. Also for the trainers, it can be frustrating for them because they don't actually understand why a trainee is not picking this up, because they can't see what they're seeing. They can't understand why this picture looks confusing for them. So by providing eye tracking to that, it gives them an opportunity to be able to get that first person view and start to understand exactly what's happening there. We use the expert performance approach, which is typically applied in sport, so that we can actually isolate down skills. So we're looking at, we capture expert performance first. We might do that in simulators, low fidelity simulators that might be, you know, some kind of piece of plastic or pork or something like that, that, you know, typically would be used for training if it's not, you know, if you're lucky enough to get some lab training. And we then up to cadaveric training as well. And then looking at transferring that into the real environment, so live scenarios as well. And then we also are interested in then identifying the underlying mechanisms. So it's not enough to just say, we'll train people, and some people are good and some people are not good. You know, why are they not good? Is there something wrong with, is there something that you can teach them in a better way to help them to become better? Have some people got innate capabilities that make them a faster learner than somebody else? You know, can you spot that? How do you categorize that? On what elements? So somebody really good at visualizing the anatomy, for example, but they're really poor relatively with their hand-eye coordination. How do you know that unless you can find a way to break that down, really? So looking at that, and then how do you actually put that into practice and training people as well? How do you put it into a tangible form that you can say, okay, I know this knowledge, now I want to apply it and see if it's actually making a difference to people. So that's what we do. When we talk about expert novice difference, we're aware that an expert is a very relative term. And so people who are called experts may not always be experts, and people who are not called experts might actually have a high level of expertise. So we use the term expert as somebody who has a lot of experience and has demonstrated, you know, a level of skill, proficiency in that area. But we're aware that it's not a dichotomous term. So, as I say, we work a lot. We typically we've been working with teal cadavers, which are specially soft and balanced cadavers at the University of Dundee in their Centre for Identification and Human Anatomy. And that's given us a really good chance to be able to visualize quite realistic anatomy to be able to work with this. And the other thing that we've started to do, this study actually got interrupted by the pandemic, which was really frustrating. We had we'd followed them, we'd given them traditional training compared to teal cadaver training, and then we took them into Perth Royal Infirmary to actually track them and assess them. We've also developed clinical assessment measures as well in collaboration with our anaesthetists to check the clinical performance against the other metrics. And so we were looking at comparing this. We got about 11 participants down, and then the pandemic hit and everything closed down, and we were locked out of hospitals completely for a good couple of years. You know, I've had to give longer than that to get really just beginning. So that study's just about to kick back off again because we've now got access once again. So, but we got some promising early results for that. We're looking at developing our software further and further, you know, continuous development. So we want to kind of become the Garmin as such of medical training, you know, and we want to work with other partners. So we're interested. We know there's people who are actually partnering Garmin, and we've spoken to them, and you know, we're interested in working with other people who are looking at metrics as well to see what we can complement there, essentially. We'll also look to other things like hand tracking. And again, we're talking to other companies to develop solutions to this. This was an early one that we'd developed in a master's project ahead of it, just to see if what the clinical utility of tracking hand movements was. And so this is something that we're following up. We know that hand-eye coordination, people talk about hand-eye coordination a lot, but most people are not actually measuring both the hands and the eyes at the same time to see if they're actually achieving that. And so we've been looking at the underlying mechanisms as well. So somebody is, for example, if somebody takes longer on a procedure, why are they taking longer? Can you use attention, measuring attention, for example, to see what is going on that is actually costing them time on a procedure? Okay, and there's lots of, this is not new, eye tracking, of course, and you know, in many domains has been around for a long time, and it's been around in medicine before, and there's been lots of evidence that there are these expert novice differences in the way that people use their eyes across different things, like, you know, from chest to aviation to radiology to laparoscopy, and now we're bringing it in. There has been some work done in regional anaesthesia before. It typically has been more qualitative, more kind of heat maps. So we're trying to make that a bit more robust. And also now, of course, with the evolution of robotics as well and surgical skills, this is another real opportunity there. Now, I can't play this next part to you because I can't put it out in video because it is academic material that I'm not allowed to share. So I'm just going to bypass this, but I'm going to tell you what happens here though. So basically this is a trainer, this is a trainee. What typically happens is the trainer, in this case, took about 15 seconds to do this regional lock, okay? And all the time he's focused on the screen. The novice they typically would take about, some of them took as long as 30 minutes, but generally they take about 10 minutes or so to do the same thing. And bear in mind, this would be on a patient. Patient's got somebody stabbing them around with a needle for 10 minutes or 15 seconds, what would you choose? You know, and part of the reason why that is because there can be a lot of shifts in attention. where they're not actually sure what the anatomy is, so they're trying to change well, we actually don't know this yet. We're looking at investigating this. Is it that they're just trying to change the camera angle in the probe, for example? How much of it is that? How much of it is that they're buying a bit of thinking time because they actually have no idea what's going on in that screen? They don't want to admit it. So they're kind of like, I'll look down here for a moment and do something, so I suspect there may be a bit of both going on. And of course, there's social inhibition going on as well, perhaps where people are aware that they're being scored and they're performing and they're being recorded, and that might throw their game a little bit. Interestingly, sometimes we've noticed that can happen with more qualified consultants who are trainees on regional anaesthesia. They can either have a really fast learning curve, or they can be maybe not used to being assessed in the same way as they would have been as a trainee, and so that's quite an odd situation to be in sometimes. So we're interested, of course, in looking at the different reasons why there may be differences between experts and novices, so that we can help to train them. So we know that there's more feature-based processing in novices and a more of a mixture between top-down and bottom-up processing in experts, where they're building up a map, a kind of saliency map of with repeated exposure, because they're getting a lot more exposure to these scans, basically. So there's a bit of a memory aspect there, recognition, but also their superior knowledge over the years as well. So it's how do you help novices to reduce their learning curve to be able to think more like an expert, essentially. We know that to do this work, we have to put evidence behind it. So we're busy trying to do studies and write papers, etc., to be able to support what we're actually doing. So here you can see this was on a study that we published last year, the year before. The top here, the top left, is a novice who was quite a slow learner, and you can see their top, this was their beginning trial, and then after 20 trials, 20 of these block procedures repeatedly, there's not a huge amount of change there in their spread. That heat map has a spread of attention across the screen, bearing in mind that what they're looking for is a nerve, which is representing a very small part of that screen. They're clearly looking quite all over the place. The second row starts off again novice, but they're quite a fast learner. Okay, so we were able to cluster different levels of performance here. And then at the bottom, this particular participant was actually really good, and he'd no experience of regional anaesthesia, but he'd been trained on difficult airways, so he had transferable skills, and he was really, really good when he came in. But by the time he'd trained a bit, he was down that on the right, bottom right-hand side, what you would expect to see with an expert, really. So very useful to be able to categorize performance like that. And we put this into practice on training courses. So next week, we start on our 6th year at the Regional Anaesthetic Mastery Learning course, which is supported by ASCIL Academy. And so we go up there and we have 2 eye tracking stations where we're giving people either visual feedback and a whole feedback experience, or we're showing them their learning curve progressively. And we've got all sorts of fun things planned for them, like beat the trainer and that kind of thing, to help them, because they quite enjoy the competition of it. And we're looking, we've done some work also in surgery as well. So we're looking at expanding work in surgery. This is not us. This is just other evidence of other eye tracking being used, but this is us. We were over at Kirkland's Medical Centre doing some laparoscopic surgery here. And then we're also working in AR and VR as well. So we're working with various people on that we've been recently funded for on augmented reality for a thoracic epidural. And then we're also looking at just general VR training. We've got a VR block room and another study that we've not put the eye tracking in yet, but we are looking at doing that because our partners are in Australia. So that's the next challenge. So in terms of challenges there, I would say for anybody that's, I don't know if any of you in the room have got any entrepreneurial aspirations in terms of actually commercializing anything, but if you do, there are some challenges there. So certainly in funding, whether it's academic or commercial funding for medical training is quite difficult, I would say at the moment. It's something that it's much easier in the States because it's a private healthcare system, but to do it here is really quite difficult. And I don't think the funders have totally caught on to the importance, as I say. So I think our next plan is to try and galvanize some support to help them to be aware of the issue. IP can be always challenging as well, because we typically work with either other bigger companies or commercial or sometimes research council funding that we're funded on or subcontracted on, or we might be collaborating sometimes. And so there's always a bit of a minefield working with other universities, working with different people, you know, how you deal with all of that side of it. And it can cost a bit of time on just sorting all of that out. Access to reliable developers can be challenging as well, because if you're not a computer scientist, you don't really know whether somebody's good or not. You know, and I've had various different experiences, bad, good, you know, but it's really difficult to tell. And so it would be really useful to be able to have more information about how you find that kind of thing out. How do you find good, reliable people to either contract or hire, as something that I'd be really interested to hear. Organizational challenges. So medicine, for example, is built around competency rather than elite performance like sport is, because they don't have the same opportunities sometimes to have that repeated practice at the moment. But there can be attitudes about it as well. Sometimes people are burnt out and they don't want to have to do more training as well. So there needs to be some cultural shifts there, as would have happened in aviation when that first changed, really. There's also all sorts of things like just things that you don't even think about, like really poor wireless connectivity when you go into hospital to try and collect data, or something that I hadn't realized at the beginning when I was working in mobile eye tracking, is that nearly every doctor wears glasses. and glasses sometimes with eye tracking can be problematic depending on the glasses, you know, and so it's got a lot better, but that's typically been a bit of a problem. Data security as well, you know, and who's holding the data, etc. So I've tried to use what I've learned in medical education to try and extrapolate, to come back to the mental health field that I started in and try to extrapolate some of what I've learned there as well. So I've built a series of labs that are all around simulated training and anxiety and mental health. I've got a face processing lab. This is probably the quietest one just now, although I have got some projects going on in it, but most of the work's been in some of the other areas. So we're looking at different things like cognitive biases for social judgments, etc. there. Social anxiety training lab. This is where we are doing some active creating training paradigms, mostly CBT based, but not all. And so we've just set up a new VR lab with eye tracking that we're going to be using shortly as well for that. And then this Minds Labs is a series of, you know, platforms that we're trying to develop, really, so that we have a data curation platform, a sensory metrics platform, and then a data content creation platform with a more therapeutic aspect. So digital mental health tools, we're interested in diagnosis, monitoring, treatment. It may not be at clinical levels. A lot of what I'm interested in doing is at more of a coaching level, so it's subclinical, but it's people who, if they don't get help, might end up becoming clinical. And digital biomarkers, of course, has become a really big area with this. Digital phenotyping, and that's something that, you know, we're involved in. We're looking at, for example, you know, well, we're not looking at, but some of the work is looking at things like relapse and schizophrenia, for example. You're looking at smartphone data, and there's some evidence to suggest that, some people found digital markers of self-harm, suicidal tendencies, a number of things. So we're looking at that, but again, there's a lot of work to be done there in terms of evidencing and safety and elements that, and trust, public trust as well, which I'll talk a little bit more about in a second. And then looking at some of the types of things that are challenging as well, like what should be, if you're recording, these are just some examples that I've built of looking at proximity, for example, walking behaviors in a VR scenario. What happens where there's no movement collected by the sensors? Is that because it's not picked up data, or because the person's not moving for a reason? So there's an interpretation of data in these types of scenarios is something that, again, needs to be understood better. So the more work that we can do in these aspects, the more we'll start to understand a fuller picture. Did I miss a slide? No. Okay, so here is what I'm really concerned about. Okay, this is the kind of thing that you can find on the internet, right? So here are some of the video games that excel at treating social phobia. Really? Has there been any work? Is this just somebody put this on? And then if you don't know anything about it and you go on and you're buying games that you think are going to treat social anxiety or something else, that's really problematic. And there's a lot of stuff out there. There's a lot of digital. I've met so many people who've said that they're developing a digital mental health app, and they're maybe a marketing student or something else completely, that got absolutely no background in mental health, but they just think that would be a good idea. This is a big problem. So we will come on to the legislation. Other aspects, efficacy issues with other digital interventions, looking at just over half mention the evidence base, and only as little as 6% in some cases, when these have been reviewed, have provided evidence. Okay, so again, big problem. It's great that the technology is there, but it's using it responsibly. There has been some good evidence coming out of University of Southern California and other places that are working in digital VR therapies, for example. And so there is certainly a lot of promise there, but there's still work to be added to this to refine and to take them on to the next step, essentially. I'm going to not play the video right next to the time. Some other things, again, just looking around at websites that are, so here's one that didn't have any evidence presented on the website. Why not put the evidence on if it's there? Digital biomarkers for facial recognition. This is something that we're working in. We're working on a project collecting this just now, but there's lots of ethical aspects there, and are there ways to be able to extrapolate information from facial expression, for example? It doesn't involve recording video and storing that as well. And also there's a lot of suspicion from the public around having, their faces kept on file or even recorded. So there's aspects there that need to be worked with. We're trying to work with objective metrics, a full suite of sensory metrics, really, to try to get around some of this stuff by having more remote monitoring that isn't as intrusive. And so using various different measures here that we can, even things like thermal cameras, for example, that are very unobtrusive. You're not having to wear non-wearable passive sensing. That's potentially a solution there. And then also looking at, I mentioned earlier about the personalization, the need for personalization. The only way to do that is to curate a lot of data to look at the patterns within that for profiles and cohorts. And that's something that we're trying to do at the moment, is pull a lot of data together to be able to inform other researchers and clinicians in the area about what they want to be looking at. We realize as well that there's a lot of barriers to accessibility in technology. So this was a project I was working on with a student at Carnegie funded project where we were looking at virtual tours, museum tours, as a form of digital befriending coming out of the pandemic. And what we realized is that a lot of the older people in particular who maybe wanted to use this didn't have the setup. They couldn't necessarily work the laptop to set it up there. They had a fear of going into it, even though it was actually operated remotely. So we know there's issues there that people need help with just accessing digital help. I'm working on a couple of projects just now with the Robotarium, looking at, this is Rubrico and another robot called Ma, looking at trying to, what can be provided in the home or in care homes or in people's homes to be able to monitor or give them assistance in different ways, and maybe eventually, this is not looking at this, but maybe eventually help them to set up a connective method of being in touch with other people. And then we have the therapy side as well, which would involve things like, VR, AR again, or different technologies. And we are really mindful here that when we're running this, we need it to feel real. It needs to be training that actually people will feel that it can transfer to the real world. And there also has to be active controls there as well. So not just a control group, but an active control group where they're doing something else as well. And we're also breaking down performance here into lots of isolated metrics, just in the same way that we are in medicine, essentially. And using the expert performance approach here as well. That's an adult mental health. Child and adolescent mental health is another big area where, again, there's lots of hoops to jump through and concerns, and the risk of causing harm is paramount. So we can't be developing games, for example, for young people that might actually harm them. So that testing and evaluation and care really has to be in there. We know that there's been, with some of the great, interventions that have been developed, but there's been issues when they've been brought out at the beginning anyway, at least, of not necessarily having adequate controls, or this is a CBT platform for adolescents. And again, here, looking at the dropout rates as well. So attrition rates, so engagement is something that we're really concerned with. It's okay developing a game and trialing it, but how do you actually get people to use it? So here I'm looking at what games actually do people like? What do they just like apart from the therapy? And then how can we gamify around people's actual enjoyment, really? So we're working on that with another project just now, which is here. This is a European project we got funded for to help to build resilience tools for adolescents aged 10 to 24. And we're looking at helping them to deal with a lot of the digital stressors that are coming in. So messages that are coming in, social media, mainstream media, all the things that are happening in the world, climate change, all of these different things that may be causing them anxiety, and helping them to process that. But of course, that's a lot of work in terms of just making sure that we get that right for them. And of course, then projects that we're working on with Nadia here, which is the European CRISPR funded MAVCA project, where we're looking, and this idea of engagement, this is built around storytelling, allowing children from Ukraine who are experiencing trauma at the moment, of course, to be able to process some of their emotions through storytelling, and then ultimately with a gamification view there to try to carry that work on. Regulation, many mental health devices have to be registered as medical devices now in many cases. So this regulation is something that many people are going to or have already fallen foul of, and there needs to be really robust advice taken about this. And to do that, we're trying to develop a validation service as well, that we can take and run trials for people for their mental health apps as well. So the first one of them is due to kick off quite soon. And that's me just now. I think I've left just enough time for questions, hopefully. I know it was a bit of a whistle-top tour. I put here just an advert in case anybody is interested in taking part in a social anxiety study. then you're welcome to contact me.
Questions? from the audience?
Thank you, Mel. Great presentation. I just wondered if you could say a little bit more about the project that you're doing using VR for mental health training or therapy or both. I wasn't quite sure which side were.
Which is this the one for social anxiety in VR, or which one is this?
I think I sort of you started talking around it around the Face Lab kind of.
Oh, right. Okay. Yeah. Okay. So I'm doing right. I'll just tell you a bit about what I'm doing there. So it's more of a training than it's using CBT, cognitive behavioral therapy principles, but I'm not aiming it at people who have got clinical diagnoses. So in that sense, there's a therapeutic aspect potentially because it's built on those principles, but it's more of a training to help people to become more confident generally as well. So it could be used by anybody.
Okay. But are you using the face markers as part of the therapy to support perhaps personalization?
Yeah, that's what we're building towards. So we're trying to break down performance, and we are we've developed some coding schemes already that we are then looking to automate essentially. So there are various different aspects of the performance that is broken down. So there's two separate aspects to it. At the moment, we're running the part on helping them to think differently about their performance, for example, and other people's evaluation of that. But then we're developing, as we're doing that study, we're developing the metrics as well, which will then ultimately be fed back into that in a similar way that we're doing with medicine, essentially. Yeah.
I was wondering, going back to the training and eye tracking, do you have any indication of the proportion of the sensory input that the expert is processing? It's just going through the eyes, and how much of the input is touch or proprioception?
Yeah. So it seems to be that certainly in anesthesia, which is what I've had most experience in, but I think it's probably the same from looking at surgeons as well, certainly in some of the aspects. It seems to be that trainees rely very much on their visual senses at the beginning. And then there seems to be a transference at some point where they're relying much more on haptic information. We don't know at what point that occurs. That's future work for us to do, to see can you isolate when that starts to change and why that starts to change. But I think that's one of the other reasons why there's a reduction in these shifts in attention. Not only are they recognizing the visual anatomy better, but they're also not as directed by their visual senses because they're getting a lot more information haptically. Yeah. Yes, we do want to do that, and we've been talking to various potential partners on looking at that, combining the EEG with eye tracking and easy mobile sets that people can use when they're, we don't want to make this too lab-based because we will lose a lot through that. So yeah, we're really interested in that, and also decision making, when, at what point, what are they doing with everything else when they're making the decisions. So yeah.
Are they even looking right now at like the haptics, the things that they feel at all? Because it looked to me like they really look mostly on the coordination rather than what is it that they're feeling. If they then start to kind of rely more on the other side, do we have any insight on the other side? No, but we've just talked to a commercial partner who's going to help us with that as the next plan. So the plans for that are in motion to be able to help us to link up both the haptic senses and the kinematics as well with the eye tracking.
On the same idea of surgical training and anesthesia, so you had a study where I think you were trying to demonstrate the difference between novices and experts looking on all these features. Have you started to look at how you can use these features? You alluded to that, but showing them to the trainer, like what information do you show them? How do you distill all this control of
Yeah.
behavioral data and eye tracking data.
So what we're doing, for example, with the regional anesthesia course next week is we show them after they do a block, we do a debriefing procedure with them where they look at their ultrasound video, they look at their eye tracking, they look at them, they have the experts, they have theirs, they're able to then reflect on where the differences are. Now they pick up quite a lot from that. Not only are they aware of their eye movements, and we've got their learning curve instantly produced, so they can see then where they have, if they've had a big peak, they've suddenly, you know, taken a lot longer on one trial. We can then take them back and say, what do you think cost you the time there? And they're involved in working that process out. So self-reflection is really important as part of this. Yeah.
Do you have you considered, like, along the same lines, but I guess if you collect enough data from the experts, you can maybe train a model that knows where are the regions of interest that the trainee should look at.
Yes.
And then maybe you can have some AR to overlay, okay, these are the, you know, points that you should.
Yes,
looking
I
at.
put in a funding application for that, didn't guess it, but yes. Yes, please. That would be lovely. Yeah, so if anybody, that's the other thing I want to say, if anybody's interested in any collaboration, there's lots of opportunities because all of this work is in its relative infancy. And I'm a real believer in collaboration, so I don't want to do it all myself. I need other people that are good and have got lots of things to bring to make change, because you can't create that level of change on your own, you know. So if anybody's interested in those areas, then do get in touch. Yeah.
And do you have any insight from your own work or others you've seen in terms of any longitudinal changes in the effectiveness of VR therapies? How much actual effect is there in terms of the impact?
Not enough work has been done in it yet. It's too new, and many of the VR companies that are in medicine at the moment are not assessing. They're not conducting research on it. And so it's really difficult to know that. So we're looking at it, but it's going to take us a bit of time to be able to look at that longitudinally, you know.
When you use these VR simulators, have you used them for also the technical skills of what you were showing for anesthesia? Right?
Mm-hmm.
Have you seen any differences in the eye tracking? Quality of the signal and how you show it?
So in VR, we've not actually collected eye tracking in VR yet. We're working with partners in Australia, University of South Eastern Australia, on VR projects. They've made the environment, which is great, and we've run some testing on it, but we haven't put the eye tracking into it yet. So that's the next thing that we want to do. Bill, I've just finished the VR studio with eye tracking in it in Heriot-Watt. So yeah, we're actively just at the moment putting it in the HoloLens. We're connecting our software to HoloLens 2 just now, which is unfortunate because it's things are moving on. This is one of the other challenges, I think, actually, is the rate of change of technology is really problematic. When you're integrating, you have to keep integrating all the time with new systems, and that is a challenge, I would say. Yeah.
When you analyze those, sorry.
Okay, so usually when we introduce new technologies, we will also introduce new work and learning curve for people to learn, adopt the new technology for training. Just wonder, for the eye tracking case, when you introduce this new technology for the training purposes, are there any kind of new things that people need to learn or work they need to do to make it work?
So for the eye, yeah, so in terms of the actual participants themselves, they shouldn't have to do anything different than they would normally do when they're being eye tracked. It should be, they don't really notice they're there, you know, basically. We don't want them, we want to capture their performance exactly as they would be in a normal training situation. So we've tried to make sure that we don't over control the environment, and we try and use the data to you know, control the data rather than control the environment. In terms of the people operating the equipment, until fairly recently, it was really difficult to get a good plug and play mobile eye tracking system that you could just give to a clinician, because the calibration was so difficult on it. Now we're working at the moment with Pupil Labs, and they've got really good you don't really need to do much calibration, if any, on them, and they're really good. So they're working neural networks. There's various different, and then C True Technologies is another company that we're looking to work with because they've just brought out really cool glasses as well. They've done very well in review as well. So that's much easier. Now that we've got them to work with, it's making our life a whole lot easier, but we do need to integrate. We're using the latest pupil ones at the moment. We haven't integrated them with the software yet, so that's the next thing that we have to do. We've made our software so that it is plug and play as much as possible, so that it's really easy for a clinician just to press start and get the data, and they pretty much don't have to do anything else, you know. And that was the whole reason that we made it for that, because we didn't want it to be a research tool, we wanted it to be a training tool.
Curious if there's any questions online, perhaps.
Let's see. Do we have any questions online? No, there was no comment. Okay.
Right, yeah.
All right, last chance for questions for Mel.
Well, just one thing, just before it, but just taking off from what you said, the other thing that I think is really important with any technology and using it in training is that they get trained generally on the technology itself. With eye tracking, it's not been such a problem, but certainly with AR, VR, anything like that, they need a period of time just to be trained with the equipment before the actual training starts as well.
All right,
Okay,
well,
thank you.
thank you very much, Mel. And I believe there should be
There is
snacks.
some snacks out there.
Indeed.
I don't know, Mel, if you can stick around for a little bit to partake of the snacks.
I can